Dr. Afton Hassett. A number of us know Afton from ACR and ARP. So Afton is at the University of Michigan. She's a clinical psychologist. She's an associate professor in anesthesiology and has some leadership roles in pain there. She's done a lot of work in the intersection of mental health and pain, and is going to talk about some aspects of her work there today. Afton, for those of you at Thurston who know about Backpack, Afton, I think I've mentioned to you, we've been talking with the Backpack folks at UNC, and we actually tried to get Afton to come and talk to us in person in conjunction with a Backpack meeting at UNC, and that didn't work out the way we were hoping. So here we are online. But if there are questions at the end of the time here, that might be a good opportunity for anyone here who might have questions for you about your role there. We've been talking with people at UNC about, potentially doing some collaboration. So, but we want to hear about your new work that you're going to talk to us. So Afton, you can go ahead and take it away.
All right. Can you see my slides all right?
Yes.
Great. Okay, so I am going to talk a little bit about the power of resilience in the context of chronic pain. Here. All right, these are my disclosures. And so to give you a sense of the work I do, I think it's kind of interesting to think about the path I've traveled, because it's been pretty non-conventional. I mean, most of us in psychology and in health really start by considering really important, factors like illness. And most physicians really focus on disease. Epidemiologists think about risk. And psychologists typically think about psychopathology. And yes, that was really very true of me, because psychopathology is incredibly important. And when I came out of school, I decided that I really wanted to understand the role of catastrophizing. How can a cognition about pain really impact the experience of pain and depression? And so I looked at this in women with fibromyalgia compared to women with rheumatoid arthritis. And I found that pain catastrophizing was important, but not as I expected to be the be all and end all. No. As a newbie out of my doctoral program, I had not found the key to the experience of chronic pain. And what we really saw in our data is that patients that we examined were really a mixed bag. Yes, we had depression and anxiety and lots of pain catastrophizing, but we also saw people who were stoic or happy or playful, just very, very different affective styles. But being stubborn, I kind of doubled down on psychopathology in my K award, and I was working with Len Siegel, the chief of division of rheumatology at Robert Wood Johnson at the time. I got to Michigan in 2010, but before that, at Robert Wood Johnson, my chief, Len, was very interested in Lyme disease, and he was a leading expert in the world of Lyme disease. But where he was most interested, not just in the infection, but really in the aftermath. And what is this chronic Lyme disease? And to his eye, it really seemed to be the manifestation of psychopathology. So he said, hey, for your K award, let's really look at axis 1 and axis 2 psychopathology in these patient populations. And that is what we did. But guess what? We were wrong again. It just didn't explain enough. Many of the people that we examined were healthier than the people who were actually conducting the psychiatric interviews. So there he was, kind of like the Grinch sitting up on Mount Crumpet, staring down at the Who's, wondering, how is it that people could have so much pain and so much life disruption and functional setbacks and relationships falling apart, losing their jobs, and yet remain really steady, really almost happy? And that struck me. It's like, what is this? And so I went to the literature and started kind of digging around, what do we know about pain and positive emotions? And I started by, looking at this beautiful model put forward by Barbara Fredrickson, who's then at the University of Michigan, is now at UNC. And she talked about how it is that positive emotions can actually build to a wave that they make one more buoyant. And also about the same time, so this is back kind of the mid-2000s, The very conservative American psychologist had an entire edition dedicated to positive psychology. And I started thinking there's something here. And even in the world of pain, Alex Zoutra and Mary Davis at their lab at Arizona State were really coming up with some fascinating ways of looking at the process of positive emotions and how they might be protective in patients with chronic pain. And even in our European colleagues were maybe even a step or two ahead of us in really thinking about these factors. And so I went back to my K award data and looked at a subset of individuals that had chronic Lyme disease that actually met criteria for fibromyalgia, because I felt like at least I had kind of a cohesive cohort. And we looked at emotional processing. So if we thought about both negative emotions and positive emotions in some context, and I worked with my intern at the time, Laura Simonality, and we kind of came up with this rubric of thinking about affect balance, which means that we can have positive emotions and negative emotions at the same time. And we all kind of have a style of the way we are in the world. And so we use the positive and negative affects scale to categorize our people with fibromyalgia as being either kind of a depressive style, which is very common, that's high negative emotions and very low positive emotions. We looked at them as potentially being healthy, because remember, we saw that healthy subset. So that would be high positive emotions, low negative emotions. And then we had these two other categories. There was low, which were people who had both low negative and low positive emotions. And these people were kind of mellow, not terribly emotional anyway. And then we had the reactives, which were much more like my Hispanic family members. There were a lot of emotion, high negative and high positive at the same time. And when we kind of categorized them and looked at what it looks like across this group, we found that having a depressive style was much more common in patients with fibromyalgia compared to healthy, very, very low. And that this depressive affect balance style, as you might guess, really put people at risk for having more psychiatric symptoms, greater pain severity, and worse functional outcomes. So there's no surprises there, but where the action was looking at the low and the reactive levels. And what we saw in reactive patients is they just looked more like the healthy people, right? They had lots of positive affect, but they also had a lot of negative affect. And it appeared to potentially positive affect might actually not only just be beneficial on its own, but it might actually buffer the effects of having negative emotions. So future me will replicate this with my friend Kim Sibel at the University of Florida. And we looked at this in chronic low back pain, affective style, and found that, again, the reactive style was much more like the healthy, that really it was protective, even though more people with chronic low back pain had this depressive style, and that was associated with all bad. And then Kim also had a separate sample where she also looked at healthy people with affect balance styles and found out, yes, they're more likely to have these healthy styles, and that here too, the healthy people who did have a reactive style really, again, looked much more like the healthy people, even in terms of pain testing of physical stimuli. So I would continue to motor on for a while in my career at Robert Wood Johnson until I hit a crisis point. So the crisis began with me doing some consulting for a pharmaceutical company out there that was very interested in novel pain outcomes. And so I helped them think about quality of life in new ways to assess this. And they called on me because they had just gotten the videos back for when they were doing an RCT looking at a novel compound in rheumatoid arthritis, a B cell inhibitor. And what they found is that the patients before the assessment looked very, very similar, or before the intervention looked very, very similar. So these patients looked depressed. They were talking a lot about loss. Their affect was kind of flat, and they seemed kind of hopeless. Then after this very successful drug trial, they had more videos. And in these interviews, the second set of videos, the patients looked very different. They were more animated. They were talking about about having less pain and about regaining functioning and doing some activities that they always hoped to do. And they just looked different. And my colleagues at the pharmaceutical company kind of turned to me, well, we think this is something important. Can you tell us what it is? What are we seeing on the second set of videos? And I looked at them and I said, I'm a psychologist. I've seen this before. This is happiness, but of course I have no idea how to study it. And so I took this crisis. And as often with crises, there is an opportunity. And something that I've kind of found in my life more than almost anything else, I've always benefited by something like dumb luck, right? So I reached out to somebody I probably had no business reaching out to. I reached out to the former president of the American Psychological Association, a leader in the field of positive psychology, really kind of the father of positive psychology, and just a generally big luminary in the psych field, Martin Seligman. And I sent him an email and he wrote me back. And I told him about my dilemma of trying to define who these people were. And this company is very interested in kind of thinking about quality of life. He said, this sounds great. I'm glad somebody's looking at positive things. So I will meet with you. And so some time later, we find ourselves in a Starbucks with my pharmaceutical company colleague sitting across from the Martin Seligman while he's eating an egg salad sandwich and explaining to us that in psychology, we think about all of these really important factors: sadness, fear, depression, guilt. And it's important, and our job as psychologists are to help our patients get to zero, to eliminate these things as best as we can so they can go on and lead their lives. But he said the failing of psychology really was that it didn't really target, it thought about, but it didn't really target these other processes that were incredibly sparing, that could really confer something critical. The notion that they were protective and they could lead to resilience was something that we had not put enough stock in. And so at that point forward, I think I was hooked, and I was really interested in this concept of resilience. And so Marty gave me a lot of things to think about. He put me in contact with people to talk to. And I thought about the factors that, which do not kill me, can actually make me stronger. So what we know is that while there are a lot of competing theories about resilience, there are kind of some shared principles. And when we think about resilience, we think about it in terms of the ability to adapt to adversity, right? So without adversity, there is not resilience. So resilience is your ability to bounce back. What's fascinating, though, is while resilience often is a trait, it also is dynamic. It can be a state as well. And as a dynamic process, we can actually build it. It is a malleable factor that can be enhanced with training, targeted interventions, and just teaching people to cope more effectively. So we know that resilience is not something you have or have not, that resilience really is a capacity on a continuum. So you could have low resilience, moderate resilience, or high levels of resilience. But there is one thing beyond that, which is fascinating in the medical literature. It is actually our ability to thrive despite disease or pain or adversity. And it's this thriving where one's life can actually be better than before. I mean, I certainly have talked to patients with chronic pain who say, you know what? I hate this, but I wouldn't trade it for the world because it changed everything. It changed who I am, what I do, who I love, my whole world. And so it's these people who thrive that are incredibly inspiring and interesting, and understanding more about them and how to teach others what it is that helped them come to this place where they're actually doing well. Because truly, this notion is how to embrace these processes that are above zero. So we have resilience here, and then we add to it the notion of pain. Pain, by all accounts, and all people in neuroscience who I know who study it, kind of come to the same conclusion. Pain is weird. It is just a strange, slippery, fascinating process that is complex because it makes up cognitive, affective, and sensory processes. They all feed in there. Pain is processed by a clear set of neural areas, structures, and networks in the brain, but these nicely overlap with the same areas that process thoughts and emotions. And as such, thoughts and emotions have the ability to greatly influence how we experience pain. And some examples are that we now know that tissue damage or inflammation in the experience of pain is optional. There is the process of nociplastic pain that, as we see in fibromyalgia and often in chronic low back pain and other chronic conditions, where damage is not required, that the brain can quite adequately either amplify a very small signal or create pain quite simply on its own. We know that our maladaptive thoughts, such as pain catastrophizing, fear avoidance, and pessimism, can all amplify pain in experimental settings. And we also know that adaptive thoughts are also excellent at decreasing the experience of pain. Even experimental and prospective studies, we see that pain self-efficacy and optimism even are powerful ways to dial down pain. Intense negative emotion, there is a tremendous literature here showing that depression, anxiety, and anger can all make pain much worse, but so can positive emotions and even laughter dampen the experience of pain, even at the neural level. We have shown in our own studies that processes that take advantage of attention and distraction, such as virtual reality, can greatly experience the way pain is interpreted and felt. In this study that we conducted with Frey and colleagues, we actually gave women in the first stages of labor virtual reality goggles that they could use for every other contraction set. And what we found is they were able to decrease their pain by 40%. And I'll tell you, for the contractions for which they weren't given the goggles, some of them were yelling for the goggles. So there are some really practical, powerful things we can do with attention and distraction. But interestingly, social factors are really important in the experience of pain. Social support decreases pain, and social isolation greatly increases pain. And the sense of social isolation was certainly made greater by the experience of the COVID-19 pandemic. And crazily so, dancing in synchrony with others to Gangnam Style has been shown to decrease the experience of pain. So all sorts of crazy things help bear out how it is that pain is so weird. And we think of pain as just dynamic and multidimensional process. And as such, really our approach to chronic pain treatment needs to be multidimensional and dynamic as well. So a model kind of helps us maybe organize our thoughts. I like this model by Palit Sharit and Tonya Palermo, Roger Fillingham, Emily Bartley. They've done a beautiful job of describing to us what is this notion of multidimensional pain resilience. And what they propose is that pain resilience really is a bunch of factors, right? Psychological, social, lifestyle, and health, and biological. And this process is affected by everything from historical factors to socio-cultural factors to environmental factors across the lifespan. But as these accumulate, they have a great impact on healthy pain adaptation, which results in improved quality of life, increased function, and reduced pain. So how do we begin to manage pain in the context of pain resilience? So my colleague Patrick Finan and I put forward a paper several years ago thinking about this, that if we consider positive activity interventions, these are really the interventions that are born from positive psychology, gratitude, acts of kindness, best possible self, 3 good things, that we could think about these in terms of being interventions that are not only non-stigmatizing because they're working towards resilience and not psychopathology, but they tend to be more engaging, they're fun to do, and they're scalable because you don't need a psychologist to put them forward. We see these as being effective because, again, resilience takes place through the upregulation of positive psychosocial factors, and these tend to feed on each other. The more you increase positive emotions, the more likely you are to increase positive engagement, the more likely you are to increase positive social contacts. And then we talked about how resilience combines both trait resources, things that we naturally come out of the womb with, kind of being more an extrovert or being a more optimistic style, to more state mechanisms, the things we can manipulate, like positive events, positive emotions, how people cope, and one's perspective. So because state mechanisms are easier to build, we kind of target those, but the others do change too. So the question of why should we bother with resilience? Well, the data are good. The resilience strongly predicts everything we want in chronic pain outcomes, from having less pain, having more focal pain, less analgesic use, less sleep impairment, quality of life, et cetera, are all impacted by resilience. So this is really a critical factor for us to think about how we can start improving people's resilience, often through teaching psychological adaptation types of interventions. So I'm a golfer. This is what keeps me sane when I'm not doing research, when I'm not thinking about how to keep the ball out of those trees on the left side of the fairway. I'm thinking about what really is going on psychologically and socially, and how do we translate what we're learning in research into ways that we can actually help our patients become more resilient. What we often find is that we spend less time thinking about the factors than putting them forward. And so number one question for me is, what cognitive, affective, and social factors are the most important in the experience and response to living with pain? And so I gathered them into this little group as I titled my talk, Joy, Optimism, and Love, because they cover three large categories. So joy is the first category, and it really refers to healthy, positive emotions and what role these might have in pain. So we talk endlessly about negative emotions, and most of our studies, if you just do a PubMed search of depression, anxiety, and pain catastrophizing, you will get many thousands of hits, right? And that's important because we do know these negative affective states have really important impacts on the outcomes we care most about in chronic pain, from use of medications to pain report to even things like hospital discharge. But fortunately, we are so much more than our their negative emotions. We also are made up of positive emotions. And these positive affective states, such as happiness, calm, love, determination, passion, all of these are likewise tied to really important chronic pain outcomes, right? So again, in really important experimental and prospective studies, we see time and time again, a positive affect is tied to everything we want, from decreased pain report to greater pain tolerance on testing to earlier discharge from hospital. And this is often predicated on that theory I mentioned earlier that was put forward by Barbara Fredrickson, the broaden and build theory. It really, what it puts forward is, as we were seeing in our affect balance papers, that positive emotions have the greatest effect of buffering negative emotions. And when we are under the influence of positive emotions, we naturally broaden our thought and our behavioral repertoire. It's as if negative emotions make us focus really tightly, while positive emotions just make us open up, and in a physical and a psychological fashion, to make us more open to the right solution, right? They also draw people in. So positive emotions draw people to you, kind of like butterflies to a flower. And more than anything, positive emotions promote what we want in a health setting. People tend to exercise more, have better sleep habits, follow a healthy diet, and follow what is recommended to them by their physicians and care providers when they're under the influence of positive emotions. The bugaboo is that there are some problems in our chronic pain populations in regard to positive emotions, as I might have mentioned before when we were talking about affect balance, right? These are data from the positive and negative affect scale. Negative affect in a column show a series of numbers where the high numbers are bad. You see in healthy individuals, a score of 18 is pretty normal. You got to have some negative emotion on board. But on the column on the far right, positive affect, we want high scores here. So in the healthy individuals, we see 35 as a pretty healthy score, kind of a 2-to-1 balance. But what we see in our pain populations are things a little bit different, a little higher negative affect. But what's really striking more than a little elevated negative affective scales are the decreases in positive affect. There seems like this deficit in positive emotions is almost more profound than the elevations of positive emotions. And what seems to happen was really kind of first described by Lois Verrouge and her assessment of what happens to valued life activities in chronic illness. What we tend to do is stop doing them, is that because there are limited resources, emotional, cognitive, and physical, when people are sick, they put that towards the things they have to do. And the things that they love to do get set aside. And when you do that, when you do nothing but the things you must do and none of the things that you love in life, meaning tends to get lost. We tend to lose some of our connections and our friendships and relationships because they don't get tended to like they need to be. And the joy in life gets lost. And even as we see at the level of neural processing, that the ability to even seek and enjoy positive stimuli gets lost. So we see this frequently in chronic pain and other chronic illness populations where there's a disruption in the reward processing networks in the brain. It's as if in the case of pain, that the kind of the pathophysiology, that the intense activations that are associated with processing pain actually lead to neuroadaptations in the reward processing networks of the brain, and that this leads to a reward deficiency where positive events are not even really detected. They don't activate the reward networks, and as such, a sense of anhedonia can set in, or help is kind of explain the anhedonia we see, where the motivation to seek natural reinforcers is actually impaired. So this can play out in some really kind of curious ways. And I use a study that we did as an example. So this is a little intervention we call the positive piggy bank that we have done in breast cancer populations and in healthies, but also in chronic pain patients. And what the activity requires people to do is to become aware in a daily fashion of something positive that happens in their life. And we give them a piggy bank so they have a way to remember it and a way to collect the information. We tell them every evening, think about the people, things, and events that made you happy that day. You may make a list if you like, pick one of these and spend a moment savoring it, what made it so special to you. Now write down this moment on a currency slip, use enough detail that you can immediately recall what happened later, and now add this with a date to a piggy bank, and then 30 days from now, you'll pop it open. So it's a pretty straightforward intervention. What we found, though, is a subset of people with a chronic pain could not do it. They were unable really to come up with something positive that happened that day. And these are just some examples of some of the really sad things that were seen as the thing that made them happy that day. And so third day in bed, I'm sad. That's the happiest thing that someone had to reflect on. And so that helped us understand why, or it really was a real world example of this loss. But what's encouraging too, though, is there have been some studies that are conducted that show that just doing positive activity interventions can actually start influencing and resetting the reward processing areas of the brain. Is a study that was put forward by Maria Kreisel-Lancome and Sonia Lyubomirsky and Charlie Taylor's lab. So we can undo this even at the neural level just by doing some of these simple activities. So the second piece is optimism. I bring forth optimism to make us think about more adaptive thoughts and coping. A study of optimism that we did was with Martin Seligman, my colleague Dan Claw, and Loriana V with the Research Facilitation Laboratory for the Army. And what we did is we thought about, processes that might confer resilience to soldiers coming home with chronic pain, which is a really, really common problem. The post-deployment, there's new pain or worsened chronic pain. And so what we did is we looked at these factors in the context of 20,000 US Army soldiers who were deployed often multiple times. And we observed that at the end of the period that post-deployment soldiers reported at least one new area pain in 37% of our service members. And what we did is we looked at what might be predictive. And the only factor of the resilience factors that was highly predictive was optimism. And what we found is the soldiers with the highest level of optimism when compared to the soldiers with the lowest level of optimism, we saw that those low-level optimism soldiers had a 35% greater odds of reporting new pain. But this was controlling for demographic factors, military factors, like whether they were officer or in the special services, or even combat factors, whether they were injured themselves, whether they saw battle, whether they were in IED, whether they saw dead bodies or lost a comrade. So despite all of these intense things, optimism was still protected. And we see this across studies. 70% of studies show that optimism is protective in chronic pain. And even the better studies, the ones that are experimental or of higher quality in assessing optimism, show even greater effects for these studies. So optimism over and over again is powerful. But other important cognitions were put forward by Rob Edwards and the group at the Action Committee, that cognitive processes like active coping, positive self-statements, self-efficacy, and so on are really important. There's so many cognitive processes that confer resilience that are important for us to think about targeting. And then there's love, kind of the third aspect. And love refers to our healthy relationships, how important these relationships are. And I think this might be best exemplified by a pop quiz. Okay, so this is a study conducted by Julia Holt-Lunstead, where she and her team looked at factors that decrease the odds of mortality. And this was across many conditions and populations. And what they found is that simple things like clean air, getting treatment for your hypertension, having a lean body mass index, all indeed were protective. And even factors like drinking less alcohol, which we'd assume would be highly protective, and less smoking were as protective as we think that they might be. But despite this big kahuna, smoking less for its protection of mortality, there was one factor that was more powerful at predicting mortality, right? So decreased mortality was predicted most frequently by social support or social integration, the degree to which we feel connected to others. So that's important. And I share with you a study that was conducted by one of my mentees, Victoria Powell, when she looked at almost 6,000 individuals in the Michigan Retirement and Health Study. And we looked at them over a 7-year period, and we found that loneliness was indeed to greater odds of subsequently reporting pain, fatigue, and depression. But what was fascinating is it was also strongly associated with the cluster of all three of these, which often come together: pain, depression, and fatigue. So again, loneliness, so important to conquer. And we think about our social relationships kind of as a double-edged sword. For the most part, they have great impact on both mental and physical health. And these pathways are not just behavioral, psychological, but they're physiological. But we want to be aware that there are costs that are due to abusive relationships. So toxic relationships make our health much worse, whereas benefits are for positive connections on our health are really, really powerful. So, and there is a cumulative effect both ways. So longer term toxic relationships, worse health outcomes, better, healthier relationships, better health outcomes. So how do we build these things? How do we build positive emotions, positive thought processes, and our strength of our relationships? Well, this is kind of the realm of the positive activity interventions. And we have many questions about these, like which of these are, which we consider a resilience building intervention? You know, how do they affect people with chronic pain and for what outcomes? And for whom do they work best, and how do these, and what are these mechanisms underlying? And how can we tailor these interventions to better meet the needs of unique pain populations? And what's the most effective way to deliver these interventions? This is where my work dwells. These are the questions I ask every day by the work that we do. And so as far as what really can begin with cognitive behavioral therapy and its offshoots. So cognitive behavioral therapy puts forth pleasant activity scheduling, which is a very powerful positive activity intervention that just says, 3 to 5 days over the next week, set aside time to do something that you enjoy, put it on your calendar, make it like an appointment. And it's very powerful. Just teaching people to prioritize doing something they enjoy can have a very, very profound effect. In a meta-analysis in depression, they had a 0.87 effect size, which is really unheard of. So this is powerful within CBT realm. As is just getting people to walk, which is often, suggested with CBT, and it's even more powerful when done in nature. And because CBT has offshoots, it has kind of the second wave or the babies of CBT, mindfulness, acceptance and commitment therapy, and positive psychology all really try to engage more in resilience types of interventions. And so I'll focus more on positive activity interventions, kind of just for sake of time. But these are the simple things I mentioned before, like gratitude activities, acts of kindness, savoring, reflection, and positive daily reflection. Gratitude intervention is kind of a fun thing. It's an easy thing to recommend to patients to do. We just suggest to them to Every day, write down 3 things for which they are grateful. It can be anything big or small, from the sunshine in your face to the people in your life. Make a commitment to do it every day. But every day, write down 3 different things. And this is really important because it really makes people over time start to look for the positive things of life. Again, we want to re-engage the parts of the brain that are not accustomed to looking for the good. Savoring is another positive activity intervention that can be really beneficial. Again, it's just telling people when something good is happening, slow down for that moment and enjoy it. It can be as simple as enjoying the way the shower feels on your body, the warmth of it, or enjoying a lovely piece of chocolate, and just engage all the senses and enjoy that moment. Make it last, because that's what savoring is. It is catching yourself in a positive moment and spending a minute or two to make it last. It helps us solidify it as a richer, more ingrained memory. Acts of kindness. Conducting simple acts of kindness is a stated, tried and true positive activity intervention. The way it works best, as it's been studied, is tell people to go out and spend one day doing 5 acts of kindness. And because it's chronic pain, we also tell them, do one kind thing for yourself. These can be anything, but just spend a few days planning it. Things that you think will be fun or interesting. It can be a little gift for somebody. It can be opening the door. It can be sharing a compliment. And then do one kind thing for yourself. And the data supporting acts of kindness are very strong. To help people connect, an easy way to do this, no matter how bad you feel, even if it's one of those in-bed days, is just to text somebody and pick somebody lower down your list that you've not reached out to in a while, and send somebody a text. Say, hey, just thinking about you. Maybe send a picture. And we tell people for the next week, do it every day. And just connect with new people and to try and rekindle some of these relationships. It's low-hanging fruit. These are people you already like and are connected to. Are they effective for people with chronic pain, and for what outcomes? Yes, they are effective. Positive activity interventions has been studied in a couple of meta-analyses. The most recent one shows that these simple little interventions can decrease pain intensity, depressive symptoms, pain catastrophizing, decrease negative emotions, and build positive emotions. And interestingly, in many of the studies, it showed that this effect lasted over time, up to 3 months. So now just a quick touch on the 7 or 8 studies we're conducting to try and answer these questions. This is a study that we're conducting with Dave Williams, my colleague, and we're looking at the added benefit of adding positive activity interventions to standard CBT. Can it make CBT more engaging and perhaps more effective? We are looking at this in people with chronic back pain plus fibromyalgia symptoms, so trying to target a population that might be even more difficult typically. We deliver the intervention online, and we use telehealth coaching, but we use medical assistants who do a marvelous job in doing the health coaching and follow the foam strips and checklists beautifully and build lovely relationships with the patients. The study has been completed. We're in the middle of analyzing the data, but what we've done is we'll compare patients who are in the PRISM condition, which is the CBT plus positive activity interventions, to eCBT, to usual care, and look at the data over time. Caveat, this was conducted during the pandemic, so our data are a little funky. We're trying to sort that out, but should be reporting that in the near future. Another thing that we're very invested in understanding is for whom do these interventions work and how, and more largely, as Kelly mentioned at the beginning, we are part of the HEAL Foundation, part of the Back Pain Consortium. We are one of the 3 mechanistic research centers, along with UCSF and Pitt. As part of the Backpack Mechanistic Research Center, we are charged with doing one project. And our project that is underway is to conduct something we call an interventional response phenotyping study, which simply means, can we look at effective treatments and decide who responds to what treatment? So we want to demonstrate that currently clinically derived measures like questionnaires and functional testing can predict differential responsiveness amongst different therapies, and even deep phenotyping. So things like functional neuroimaging, quantitative sensory testing, inflammatory factors might even predict differential responsiveness through to the therapies, as well as infer mechanisms for these treatments. And so what we're conducting right now, we're about 305 people into a 400-person study where we do a run-in period and randomize patients to either physical therapy, mindfulness-based stress reduction, acupressure app using an app, and duloxetine. And really mindfulness is really the true resilience-based therapy, but also really one can argue physical therapy as it's conducted and acupressure also do confer resilience. And so we're in the process of conducting the study. Hopefully down the road, we'll have some answers. As part of the Backpack Consortium, though, we also are a team that is doing the biomarkers for evaluating spine treatment study, or BEST. And BEST has 14 different sites. We are one of the sites on the site PI. And here too, we're echoing what we've done in our study, our SMART design, in BEST. And here too, we have a run-in period, and we will randomize people to one of 4 treatments, either enhanced self-care using Pain Guide, which I'll talk about in a bit, acceptance and commitment therapy, enhanced, kind of an enhanced physical therapy and manual therapy, or duloxetine. And here too, we can argue clearly ACT is a resilience building intervention, but so is kind of EBM as well as enhanced self-care. Here too, we're going to enroll about 850 people. We are a few months out from being done with enrollment, so answers soon too there. How can we tailor these interventions to meet unique needs of populations and individuals? I'll touch on these quickly. These are studies that we are conducting currently now with Mary Janovic and Sharia Robinson Lane, where we're looking at adapting standard CBT with positive activity interventions for a unique pain population. These are elderly African-American adults living in Detroit who are often very, very isolated during the pandemic. We've developed what they call the We Positive Steps program, and some of the sessions include music as medicine, life highlights, acts of kindness, gratitude jar, and savoring. So they do kind of this hybrid where they get some CBT, but some of the more positive psychology interventions. And the pilot study effects were dramatic. The intervention group had much, much better response to questions about functional status as well as pain. We have an R01 now that is a year in, up and running, to do this in a much larger setting. So we'll have that too. And then my friend Susan Murphy and Dinesh Khanna have recently published a pilot study. It's just out now, where we did the same thing here too. We used some standard CBT, we wove in some positive psychology interventions, added peer health coaching. And I can't tell you everything. You'll have to come to the poster at the ACR. But the results from our 12-week online pilot of this study were really impressive. And scleroderma, which is often not thought of, and really the focus was fatigue, but we also looked very much at pain interference. And I'll give you a quick sneak peek, but the people in the intervention group had decreased fatigue, decreased pain interference, fewer depressive symptoms, and greater resilience. So more soon, please come by the poster and take a look at that. And then lastly, what are the most effective ways to deliver these interventions? mHealth, this is kind of where we're all dwelling. These are the grants that we're seeing coming through study section. We're so invested in getting these things into people's hands. And one of the projects I've worked on with my very dear friend and a colleague, she's a oncologist who does stem cell transplantation. And she came to me years ago and said, hey, we need to do something for caregivers. They have the hardest job known to mankind with these very, very sick patients. And so we developed a roadmap. It's an app that delivers these positive activity interventions to caregivers. This is how it was first designed. They have an opportunity to interact with each other. They can do the positive piggy bank any day that they want and talk about it. They can track their symptoms with this app. But it kind of metastasized. It is now being tested in patients and caregivers, in frontline healthcare workers. It was given to them during the pandemic, during the worst parts of the pandemic. And our college students, 2,000 of them picked up the app during the pandemic too, when so many were struggling with anxiety and other mental health issues. And just additional patients and caregivers. We just completed an R01 looking at this and in patients and caregivers. Data coming soon. We'll also consider moving this app to pain, because we found that 40%, or others have found that 40% of people post bone marrow transplant actually develop chronic pain. So that's kind of our next target there. This is My Care Path. This is another app that we've developed. This is to be used in the context of prehabilitation. I developed this with my colleague Jen Walge, a hand surgeon, and my colleague Chad Brummett, an anesthesiologist. And the goal is to decrease anxiety and to build pain self-efficacy, how to deal with pain pre-surgically. The app itself collects data using My Data Helps, and we can consent to using it. Patients get 3 different educational videos. How do you prepare for surgery? The notion that surgery is painful for a reason. The pain is good. It tells you not to rip your sutures, and how some pain is okay and how to deal with it. And then pain management planning. We give them breathing guidance. We give them guided imagery. A lot of this is targeted towards decreasing anxiety before surgery and how to improve pain post-surgery, developed with my colleague Dave Williams at University of Michigan, and also Lindsay McKernan at Vanderbilt. But a sneak peek at some quick data. We just did a quick comparison, 56 people getting My Care Path compared to treatment as usual. And what we found is that those who got My Care Path greatly reduced their use of opioids. And it was fascinating. 70% of the patients in the treatment as usual surgical condition were using opioids 2 weeks after surgery, compared to 7% of the My Care Path patients. So something worked well. So other ways to translate. This is my new book. This was my pandemic project, the love of my life, and also what caused me great grief. But the goal was, how do we translate all that we know in neuroscience and what we've been doing for the last 20 years? And so I worked with my colleagues to find ways to really explain pain neuroscience, as well as the role that thoughts, emotions, and behavior play in pain processing. And that's a big piece of what we do in this book. What is the rationale for these behavioral interventions, and how it is that we can actually change how our brain is processing pain through changing the way that we think and the things that we do. Another piece of this book is where for 30 days, the reader tries one new evidence-based intervention a day. And it can be anything from pacing your activities so you don't cause a pain flare, to sleep hygiene, to increasing positive emotions, to decreasing negative thoughts, to gratitude journaling. It's a little of everything. People pick what works for them, and after they do the 30-day challenge, they build a long-term personalized plan to decrease pain and increase activity and life satisfaction. The goal is to move people from low resilience, moderate, high resilience to thriving. And can you actually trigger that? And we offer, I think it's a really great way to not only educate the patients, but I think it's a great way to offer support to people who are providing the care. I got an email recently from a physician who has a rheumatology practice in Texas, who said that he now has made a smart phrase out of this to be run through Epic, so that he can give this to his patients, and so it gives them the education he doesn't have time to do, or they don't have the time to do in clinic. And what the book leans on is this beautiful resource that's available to you now. It's Pain Guide. It's free at the University of Michigan website, or you can just do painguide.com. It has pain self-management right there, everything that we typically do in CBT for pain, as well as ACT and mindfulness. It even has resilience. I did a module that delivers a lot of these positive activity interventions. And so I encourage you to look at that. So next, what is next? Well, next is we really lean into these interventions that build on the strengths our patients already have. How do we convince them this is important and help them move in that direction? We do so by emphasizing that it helps them get back to the things that they matter most, the treatment targets that that they want more than necessarily we even want. How do we build vitality and zest and a sense of well-being and reconnecting to their social networks, and even enhancing a sense of meaning and purpose? And moving forward, we never want to infer that their pain is due to not being resilient enough, because that's not healthy and it's not true. It is just that this exists and this is a tool. And if we can help you become more resilient, you certainly can experience less pain, but also have probably better sleep, better relationships, and a lot of other offshoots. And then the last thing I want to leave you with is that moving forward, these principles don't just work for our patients, they apply to everybody. Most of these principles were developed for healthy adults. And so I teach these frequently to healthcare providers in the context of decreasing burnout and, and other negative processes, especially during the pandemic. So last thing I want to say is I want to give a nod to the people who do the hard work. These are my sweet, young, very bright and talented lab people. And they're the ones that do the hard work, but they also do a lot of good work. And so we do a lot of community service together. So it makes us a great unified team. And I also want to nod to the funders who actually support the work that we do, because without them, very little research would get done. So that's it. So thank you.
Thank you, Afton. We have about 5 minutes for questions, but I want to say that was fantastic. When you put up your slide about what's next, I think Afton needs a nap because of all of this stuff. Not because you look like you need a nap, but wow, that was just that was a lot. I know this is not all things you've done in the past 5 years, but really amazing. I enjoyed hearing kind of the trajectory of your work. So we'll go ahead and take some questions. I see Lee, your hand up.
Totally agree with Kelly Aston. That was a great talk, and I love exactly what you're thinking about. In terms of, it was great to see that, this positive is not just a trait, but a state, and that you can move people to that. Do you have data on how long it takes for these people for it to become a habit, for them to be, and do they maintain this positive outlook?
That's such a great question. And the data are a little bit all over the place because nobody's really done a great job of this, especially in pain. But what we do know, Siri's trying to jump in. Shut up, Siri. What we do know is that often we just do one thing. It really surprises me that they'll just link into one of these positive activities. It could be the positive piggy bank, or it could be acts of kindness, whatever. And there are ongoing effects. And so I think that is the piece that we do see, is that sometimes these simple interventions can last like 3 months. That's as far as it's been studied out. But we're studying it out to 1 year. And again, those are the data that we're really excited to kind of see. How long do these simple things? But sometimes the education, it's all of a sudden people are like, oh my God. A light bulb goes off and the thinking switches, and that's where the power is. And so kind of once that connection is made and there's an acceptance that, oh my gosh, I actually have some volition in this, and there's something I can do here, and positive emotions actually do matter. And in something as simple as pleasant activity scheduling, that's one of the easiest ones we've been able to make a habit, and someone that people come to most.
Is it okay if I ask one other question too?
Yeah.
This is based on an email. Actually, I'm so crediting Katie Huffman about this. Have you linked these activities with other interventions for people? So like, say, a physical activity intervention. And if you link, so Katie nudged me, commented about Walk with Ease, and we have a portal. And that maybe we could have the portal have positive activity things linked in there. And doing that, does that have people stick with the other intervention more?
These are, we kind of treat these like catnip. So this started with an observation when we were doing CBT, and the one module that people like over and over again, this is Frank Keefe's Pain CBT that has all the things we've grown to love, but also has pleasant activity scheduling. It's the one everybody does, and it's the one everybody wants to put in their plan going forward. And so we see that over and over. And so to us, it's like, oh my gosh, how about if we had more of that? If we had more of these more engaging things and alternated them. And that was kind of the goal of PRISM. But it's also the goal of the study Mary Janovic did within the older African-American adults, to really engage them so that we could get them to do the walking, because it's positive steps. So the first program was steps, and she had a hard time getting people to engage. And so we thought, let's weave these little things in, and that changed everything. So yes, that's kind of how we are using this. And we even talk to physical therapists who say that they're doing more kind of moving ACT in and savoring and stuff like that, because again, it kind of is increasing engagement. So I think that's a really powerful element of these little activity interventions.
Well, just beautiful work.
Thank you.
I'll ask a question, Afton. You talked about one of the HEAL initiative studies and trying to look at kind of tailoring treatments or which kind of predictors of differential response, which is something our group has definitely been interested in. Can you talk a little bit about how you're doing that? I mean, I don't want to like ask you to get into the statistics if you don't want to, but that's fine if you do. But just conceptually, how are you doing that, or methodologically, what's your approach to that?
Well, you've actually opened up a can of worms, because we're wrestling with that question right now. Because the goal was to phenotype deeply. So we actually do light phenotyping, but it's very rich. And then we do something called deep phenotyping, which gets all of the additional measures, so fMRI and inflammatory factors and advanced biomechanical assessment. And with the goal being that we can identify the best predictors of each intervention, and that they would create an algorithm that would help us predict. So for example, the goal is down the road that a physician or other clinician could put into their computer, this is a patient who has high levels of depression, great levels of sleep disturbance, high pain, low motivation, and that you put those factors in, and that we would be able to say, hey, you know what, the best thing for you to do is probably start, treat the depression first. So hit them with antidepressant medication, and then send them to physical therapy, right? So that is a goal. So that's why we conducted SMARTs in both cases, so we can start getting a sense of really staging, which intervention comes first. But so the statistical approach, and kind of what we're arguing right now, is do we just predict the first four, the first four treatments themselves, or do we really think about the more dynamic regimens, how the two together? So that's kind of where we're at, and I think we're going to do both. I think that's where it's going to end up. And I think especially with the best trial, because it's going to be a little bit better powered. We'll have 400, so 100 in each cell. They'll have 200 in each cell. So I think that we're going to have a little more wiggle room to ask more complex questions and do a little bit better with kind of these dynamic regimens.
Great. We'll look forward to hearing more about how you all approach that. And we're at time. Again, thanks, Afton. That was wonderful, and really appreciate your time. And there's going to be, for all of you, there's going to be a brief survey, if you don't mind